Good morning, and thank you so much for the invitation. I was charged to talk about MRI in this debate. I have nothing to disclose in relation to this presentation. So, to look at the role of biomarkers in prostate cancer, I subdivide the prostate cancer management in these three spaces. One is before diagnosis, patients with abnormal PSA with or without previous negative biopsy, where the biomarker helps in the decision for the biopsy indication or the benefit of a repeat biopsy. At the initial diagnosis, especially in patients with very low risk groups, and the counseling for the best primary treatment option, if it's active surveillance or active treatment and what form of treatment. And then after treatment, when you have adverse pathology after surgery, for example, or biochemical recurrence after surgery or radiation. So the biomarker would, in this situation, counsel the need for adjuvant therapy and or versus early salvage therapy. As you can see, there's a lot of available commercial markers in this space, and I included MRI as one of them. So it can inform the risks and the benefits of having biopsy in the situation. For the initial diagnosis, it can help on the candidate selection for active surveillance protocols and can improve the accuracy of confirmatory biopsies, follow-up biopsies, can guide treatments for surgery and radiation, and also can inform location and restaging patients with recurrent disease or biochemical recurrence. For the third indication, we're going to leave outside of this presentation now, so we're going to focus on the early phase. The unique benefits of the multiparametric MRI as a biomarker are, as a molecular test, they will inform the risks, but they will still require the biopsy to be performed. Since the MRI helps in the optimization and guidance of the biopsy, and nowadays it's been done for every biopsy, there's a benefit right there if you use the same biomarker to inform the risk and also help in the diagnostic testing. The MRI will provide prognostic information. So the PI-RADS would inform the chance of having prostate cancer, depending on the imaging. It's clinically significant. So MRI has excellent performance in high-risk tumors, and it's well known to be limited in low-risk tumors, but those most of the times are not clinically significant, and we don't even need to know about those cancers. Again, in terms of the biopsy, it guides and improves the biopsy accuracy, and this is both in initial or subsequent biopsies. And also it can inform treatment, helping surgical planning or helping radiation simulation therapy. In terms of techniques, MRIs are done in the T1 and T2 weighted images, and there's advanced sequencing using the diffusion weighted imaging, the dynamic contrast enhanced, the DCE, and also spectroscopy. The multiparametric MRI is when two or more of these different sequences are complementing a T2 weighted imaging to provide the reading and evaluation of a prostate. Modern emerging new protocols are suggesting that only two additional sequences are necessary, and this is being called a biparametric MRI. The advantages are that it would take less time, it would preclude the utilization of IV contrast injection, and it would preserve the same diagnostic accuracy and cancer detection rates. In terms of equipment, there's always a discussion if 1.5 Tesla is enough, or if you need 3 Tesla, or what type of a coil, if you use a pelvic phase array coil or endorectal coil for better imaging. It's not the scope of this talk, but just to give you a flavor of some nuances in the technique. In terms of the sequences, the T2 is the main sequence is multiplanar, provides high resolution, and best for identification of morphology. Normal tissues usually has a high signal, and the prostate cancer usually has a hypointense, a dark signal, especially in the peripheral zone. So the T2 is this sequence for assessment of the transition zone. Couple examples, you can see the dark area located here on the T2 weighted. Here in another view, on the sagittal view, you can see a large tumor situated in the anterior portion of the prostate, and the whole mount confirming the same thing on a specimen. This is just to illustrate how it provides very good anatomical visualization in the different planes. This is the coronal, and this is axial planes and the axis, mid, and base of the prostate. There's some pitfalls. Lesions that are too small might look iso-intense and very similar to the adjacent benign. You can have heterogeneous peripheral zones due to atrophy, prostatitis, or biopsy hemorrhage. And for that reason, to avoid those artifacts, we recommend to delaying MRI 6 to 8 weeks after the biopsy to prevent, finding those things. Additionally, you can use for the T1 weighted images for better anatomical details. The second sequence is the diffuse weighted imaging. It provides functional information about the tissue microarchitecture. So if you have a tumor with a higher cell density, the water protons are not gonna move so freely in the tissue anymore. And this is also can be calculated by the apparent diffusion coefficients, ADC, that can build maps to help us visualize those areas. So here you can see a T2 weighted imaging of a suspicious area in the peripheral zone, drop-in signal on the DWI. Same thing here, large anterior tumor, DWI with a drop-in signal and the correlation with the whole mount specimen. These ADC maps, they have high sensitivity specificity rates, good accuracy, and they can also be reported to be inversely correlated with a grade. Therefore, DWI is the sequence of a choice for assessment of lesions in the peripheral zone. Another sequence is the DCE, the dynamic contrast enhancing. It's based on the angiogenesis phenomenon, so increased blood flow, microvascular density, and also capillary leakiness. And it measures the diffusion of the contrast over time on repeated sequencing in the same area. These measurements can be done qualitatively or on a quantitatively way, which requires computer modeling for evaluation. But you can see that many times DCE maps become very easy to interpret by the color coding. So you can see, for example, in this case, area suspicious by the T2 weighted. This is the DCE sequence, and the DCE map becoming very evident for diagnosis. Same thing in this case. Spectroscopy, I'm not going to spend much time about it because it has not been utilized anymore and is based on the various metabolites in the tissues. So it creates curves with peak of the expression of the metabolites for the choline, citrate, and creatinine, and depending on the profile of the curve, you would have lesions that are more likely to be benign or more likely to be malignant. Again, this has not been used anymore. PIRADS, it's a standardized way to report and to classify these lesions. This is the differences between the version 1 and version 2, which is currently in utilization. And this is the criteria how you classify the PIRAD score for DWI imaging on both peripheral and transition zones. It works like a Likert scale in terms of prognosis. Number 1 would mean very likely benign lesion, 2 a likely benign, 3 indeterminate, 4 likely malignant, and 5 very likely malignant. And when you talk about malignant, those are clinically significant tumors, high-grade tumors. This is probably the main table about the PIRAD score when it suggests that you have a dominant sequence. For peripheral zone, for example, we look at DWI sequencing and use only the DCE or the D2 to resolve borderline PIRADS 3 lesions. For the transition zone, the dominant sequence is a T2 weighted sequencing, and we use the WI only to differentiate the borderline PIRADS 3 lesions here. There has been numerous publications showing the benefit of MRI and the benefit of a fusion biopsy in terms of improving accuracy and higher detection of rates without missing significant cancer detection. This is one of the first clinical trials, the Profuse Trial, where these patients were biopsied based on fuse, target MRI, cognitive fusion, and they're using the standard templates, and the authors observed, different rates of accuracy favoring diffusion protocols. So both the cognitive fusion or the software fusion perform better than the biopsy sampling alone. This is another trial, was published this year. It represents the largest experience from the NCI group, and they also performed this prospective study when they accrued more than 2,000 patients. They were treated in a very standardized way, both from the MRI certification, also for the biopsy sampling, and they observed that with the combined method, meaning standardized systematic biopsy plus targeted, they were able to identify almost 10% more cases with 21.8% of upgrading in these tumors. They also seen that the targeted biopsy alone was not good enough because it missed almost 10% of cases with significant cancer. So that's another message, that these methods, when applied, they need to be applied in a combined fashion. I don't have time to go into detail about too many trials, but I just want to miss mentioning about the PROMIS and the Precision trials. They also show the incorporation of MRI as the biomarker, helping in the decision making if the biopsy needed to be done or not. And then later on, helping to fuse and guide the biopsy, provided a better diagnostic tool that was superior to just sampling the prostate alone. This is an anecdotal case of mine. A 59-year-old patient had a PSA of a 3.7, and he was on a 5-alpha reductase inhibitors, and he came to me with 3 previous negative biopsies. After the MRI, we identified this pie-red suspicious lesion in the anterior zone of his prostate, and we were able to target that with a fusion biopsy. And finally, he got the diagnosis of his intermediate risk prostate cancer, and on his final path, he had a confined cancer without risk factors, but a significant cancer that needed to be treated. So the key points about the application of the MRI are that the multiparametric MRI and the target biopsy, they're able to detect significant prostate cancer accurately, and they can also mitigate the insignificant tumor detection. MRI can detect the index lesion in approximately 90% of the cases compared to the specimens, and but because 10 to 15% of the significant tumors are still undetected, using the target protocols alone are not recommended at this time. They need to be combined with the standard templates. We see that the utilization of this technique has benefits in terms of a candidate selection for active surveillance patients, and also in the high-risk setting, changing the clinically based surgically plan in up to a third of these cases. So in conclusion, the evolved multiparametric MRI has changed how we manage and treat prostate cancer currently. It helps on the diagnosis, help on the management, and help in the follow-up phase. So it has become a reliable and dependable tool that is critical for the decision-making in a prostate cancer management. As a biomarker, I consider it one of the most ideal biomarkers because it provides prognostic information and also the decision-making towards the recommendation for a biopsy. If the biopsy is performed, the same test will help guide your biopsy, increasing the accuracy and also reducing the number of false negative biopsies, and it will optimize care after cancer diagnosis, helping with the patient selection for the best therapy. So, in my view, this is a good marker and is superior to the molecular markers, but we actually use all of them in combination. We're going to hear to Dr. Crawford's opinion, and I hope you guys will have your own lessons after this. Thank you very much.